Good morning, everyone. As you might gather, I'm John Glasser. I'm the, how about that, the chair of the board of the NCQA. It's a real privilege and an honor to be here with all of you this morning at the Health Innovation Summit for what is truly a historic occasion for NCQA. It is the honor to be working, I've had the honor to be working alongside Peggy O'Kane for 9 years. Now, she's a true, as you know, a true pioneer. She's a visionary whose leadership has transformed the quality of healthcare in the United States. She's got this unwavering commitment that has touched countless lives and set the standard for excellence in this industry. Her legacy is exceptional. Today, we also look to the future as we welcome Dr. Vivek Garg, NCQA's incoming president and CEO. There are few people in this country, or in this world, frankly, who have the talent, skill, and experience to carry on the work that Peggy has led for so many years at NCQA. Vivek is one of them. So it is my great honor to introduce two extraordinary leaders for this special conversation called Passing the Quality Torch. Please welcome Vivek Garg and Peggy O'Kane. Thank you. There they are.
Well, good morning. Who's starting? Should I start?
Yeah, go ahead.
Okay. So Peggy and I made a pact last night at dinner that we were going to go off script. And I actually think that you've probably been writing your own script for a long time. And I know you've got some questions for me, but we want to focus on you. And I feel like for the last few days, I've been visiting in the house that Peggy built. And it's been awesome. This community is awesome. This movement you've helped to create. And so I can imagine that you're having reflections about this community, Peggy. And she said she was up for any question. This was not a prepared question. But I just wanted to ask, what do you feel about this community?
I think this is a very unique community because whatever we are designing as our strategy for the future wouldn't happen without you all that make it happen. And when we and sometimes we create standards or measures that are kind of problematic, and you always tell us, and you also, you're so generous also with your feedback about what we should be thinking about that we haven't been. And so I just find it amazing to be in this kind of a role. And this conference, this conference is usually really good, but this year I think it's been particularly great. Oh. And so I just feel incredibly privileged to have this. I know that word has a bad connotation, but I mean it in the best sense. To be working with all of you, with our teams at NCQA, now with Vivek. I just, I feel incredibly fortunate.
Well, it shows. And I'm supposed to ask about some of the achievements that you're most proud of, but I thought there's probably one that came out on Monday when Dr. Irwin talked about your engagement in Louisiana after Katrina to help the state and the community health centers form a plan and move on their plan to rebuild primary care capacity. And when you presented him with the Healthcare Quality Award, you kind of quietly said, "This is very meaningful for me." But I think we could all see that was real. Why was it so meaningful for you?
Well, I mean, you witnessed Dr. Irwin and his character, right? I mean, a lot of this is about character. I really think that. And so having kind of witnessed what he was doing, spent days at a time with his team and like understanding the methodical way they approached everything. And you also heard his optimism, kind of his grit, actually. So I was very taken with that. I think somewhere along the way, I had the gut instinct that we could write all the beautiful rules that we wanted, but if somebody didn't make it worthwhile for people to do the thing that we're talking about, people were just going to go and do what people are busy, and we're asking them to do above and beyond what they're, and to a fault, I think, and one of the things I like about the tech stuff is if we can get it straight, we can take a lot of the hamster wheel out of medical practice and out of medical teams. So, we approach this with humility, and then people teach us how to do it better. That's what I think. So, going to the state, and, Louisiana is a small place, and everybody knows everybody. And so, we said, if we can talk to the state, maybe we can make the pitch that it's worth their while to pay PCMHs more. And it worked like a charm. So I was so pleased that it's still happening.
Yeah, it's
so
amazing.
Good to hear.
Well, Dr. Irwin told me later at dinner, he said, if you do one thing in your new role, ask ChatGPT about Peggy O'Kane in Louisiana and primary care. And ChatGPT came back, I asked it, with how you really helped establish PCMH and played a key role through all of the great work you've led and the NCQA has enabled to bring many of those community health centers are still PCMH certified and very deeply involved with the community and the population health movement.
Yeah.
So it's an amazing achievement. When you look back over the last 35 years, what other achievements are you really proud of?
You're going to ask me about the other part too, right? What could have been better?
We'll get there. We'll
Yeah,
get there.
okay.
I know you're always thinking ahead. We'll get to that part too.
I'm actually not going to be too
I
modest.
know you don't like to
about-
talk about your achievements. You're
Yeah.
always focused on the
Well,
ball.
the biggest achievement was quality when I came out of graduate school, quality was PSROs, Professional Standards Review Organizations, which basically meant peer review, which meant doctors reading each other's charts. And that is a really silly way of thinking about quality because it completely bypasses all the structural things that are missing in the system. So it's really no wonder that we had to, and there's so much work to do to get this structural stuff, but we created the first national system of quality measurement. We created an accreditation program that the employers at the time sat at the table with us and helped us write. And so those are very proud achievements. But the other thing that I really feel proud about is that maybe 5 years ago, we decided quality measurement is it's really not working the way it should be. It should be much more embedded in medical practice. The measures should flow from medical practice. And what we're really trying to do with quality measurement is to have people look at their numbers and have that motivate the change that needs to happen in the way care is delivered. So has it been a perfect journey? No, but have we got people's attention with it? Yes, we did. Yes, we did.
I'd say so. I know you want to get to the next set of challenges, but before I go there, I have a few observations about you I wanted to share and get your reflection on, not to surprise you. I feel this quiet kindness and generosity of spirit from you. I also hear someone who is very clear-eyed and willing to look at things anew. And underneath it, this conviction. You're always thinking, how do we move forward? What's the problem set? Who needs to be engaged? What could this become? Were you born with these traits, or did they come along the way? And if so, how? And how can I learn them too?
I think part of it I was born with, to be honest. I have a strong personality, not everybody's taste. But in this role, I think it's been a tremendous asset because, I don't have to tell this group how hard it is to make quality happen, right? Or how hard it is to get, like when times are tough and the CEOs of many companies are looking at where to cut the budget, it seems quality pops up in their minds a whole lot. So I feel very proud of my own persistence and like, if that one doesn't work, let's try it this way. Constantly rethinking the strategy. So I feel good.
Let me ask my future NCQA colleagues in the audience, did we get some of Peggy's persona right there? Yeah. Okay. Now we'll get to what you wanted to get to, which is what should we be focused on next?
Well, I think we need to enlarge the conversation. I think we are in the business right now of changing quality measurement to be more salient, focused on more important issues, less burdensome. These things are going to take a while. But we also have to focus on the larger environment that these quality measures are deployed in. And as long as we have such a fragmented, crazy delivery system, it's really hard to say this is an accountable entity. And when the accountable entity is a small medical practice, that's pretty hard to measure, right? And it's very hard to, again, they're so stressed and so on. So what we have to have is a policy environment that really makes it in everybody's interest to get the quality better. And I'm one of the people that believes that if you do this right, if you eliminate all the crazy, squirrely stuff that goes on because of fragmentation, we are going to have much more affordable health care. Do I think that's obviously, due to happen because it's so obvious?
Right.
Not at all.
It's not the default path.
Not at all.
So it's going to take that persistence.
Yeah, but I think I kind of took it, like anything that wasn't working, I took it as our challenge. And I think that part of what I say to you is you need to speak up and say, if you don't pay primary care doctors appropriately, we cannot do this work. They cannot do the work. If hospitals make more money by having readmissions than the penalty that they pay, guess what's going to happen? So we have the most crazy reimbursement system in this country, so it's not even neutral. It's actively working in the wrong direction. So I think you need to just stand up there, and you have the credibility of having worked at the plan level, at the primary care level. So, and I'm planning to talk about this a lot after I retire.
Wonderful,
So
wonderful.
I'll be out there with a big mouth, and you can be the nice, polite person.
So you're finally going to say what you think.
Oh, no, that's not true. People know I say what I think.
I know. That was a joke. All right, we're entering the advice portion. So you dropped a little bit of wisdom for me just there. Any other advice you want myself, your team, this community thinking about as
I think my admonition to all of us is we need to be much more intentionally working together. So I think we're all very busy in our own organizations, but we have a message to carry to the American public, to health policy leaders, and to practitioners that we're with you. We want to make this work. We already spend twice as much as anybody else, and our results are really pathetic compared to their results. So I think that, and I think you are that kind of a person. So it's one of the reasons I feel so thrilled about Vivek. I just said to Vivek that I was talking about Kate McAvoy, and I was on the board of the Milbank Fund when she was the chief operating officer, and she got offered this job. And I thought, how did they find the perfect person for this job? And it's such an important job. She runs the National Association of Medicaid Directors. And they have a lot of challenges, but she is such a strong leader and such a strong advocate for Medicaid and for the people that are enrolled that it's perfect. So,
absolutely.
Yeah.
Thank you, Peggy. And there's that kindness and generosity of spirit. I was going to ask you why you're being so nice to me, but I think that's becoming obvious. Okay, should we flip the table a little bit?
Yeah.
Okay. What do you
So I want you to tell us about yourself, because Vivek's biography tells you a lot about why he comes with this heartfelt dedication to quality.
Thank you, Peggy. I'll share with a couple hundred of my closest friends. Before I was ever a physician, I was a son. I have a father who immigrated from India, set up shop first in Alabama and then pretty rural northern New Jersey where I grew up. Hospital, ICU, clinic, nursing home, sometimes home visits, sometimes all in the same day, definitely in the same week, 7 days a week for 4 decades. And so I saw what being a clinician meant to him, being a doctor. And, we grew up in a pretty small town in northern New Jersey. Surprise, there weren't many other Indian American people there. And so we go out in the town and, hey, you must be Dr. Garg's family. And actually, my parents live close to us now in northern New Jersey. We came back after all of our training and living in New York for a bit. And we took my son out to a little gastro pub. He loves steak frites, so we took him out. And both sets of grandparents were there. And a few minutes into being seated, the waiter, probably was in his 40s, as a man, he turned to my dad and he said, "Dr. Garg?" And I knew he was talking about my dad, not me. And my dad had cared for both of his parents, cared for him as a teenager, and I could just see a little bit of that light. And it's not because of the medical care he provided, it's because he imparted this sense that he cared for that person. That I could tell there was some moment where that man as a young person felt a little bit seen, a little bit healed. And then, with my mother, looking back, she suffered from undiagnosed and unmanaged bipolar disorder for decades. And so we experienced that as a family with a lot of social stigma, a lot of lack of understanding, emergent hospitalizations against her will when things got off the rails. And I can look back now as a physician, over 40 years and say, I could think of her blood pressure and her hypertension, her diabetes and her A1C, and I could see the psychiatric hospitalizations, and I can see her kidney function go like this over decades. So for the last 3 years, she's been on home peritoneal dialysis, thankfully doing really well. My parents like to bicker about how well she's doing it or not every day, so they have something to talk about and do. But, I think we all have these experiences where you look at the healthcare journey, and there's just so much lost opportunity.
Absolutely.
It doesn't have to be that way. We have the science, the knowledge, the therapies, the interventions, the people. They're just not set up in the right way. And so I remember social workers, nephrologists, psychiatrists, friends and family members, and I thank God for them, for the relief and the care and the support they provided every day. And so then as I became a physician, I've chosen to work in environments where I felt like we were giving people more of what they deserve. And so I started my career at One Medical Group in New York, practicing as a PCP. And I thought, here's a model where people are getting more of what they want. They access information transparency, virtual appointments, good clinicians who are set up to practice well, and really loved that experience. I went on to Oscar Health, where I felt like that being in a health plan, a weird consumer tech-focused health plan where, it was the first health plan to integrate $0 copay, totally free access to telemedicine a decade ago. It's common now, and led the medical team there.
Tom Lee spoke at this conference.
And then I've spent most of the last decade in what we call value-based care, CareMore with Sachin and Liba for a brief period, and then CenterWell, which is the largest senior primary care group in the country, working with clinical teams. So the NCQA constructs are very familiar to us. We come at our clinicians throughout the year about where the care gaps are. And they take pride in serving their patients well, knowing they're getting the preventive care and chronic care they need. And then they argue about the data. The data is incomplete, it's not accurate. What about this? This patient has this other issue. So they see all the nuance and complexity. And so to one of your points earlier, Peggy, there is this opportunity to take the quality measurement ecosystem forward, put the insights in an accurate and comprehensive way in front of the people who actually work together to improve health, and to go deeper.
Yeah. So you've had a big dose of NCQA for the past couple of days. And we've been in sessions, Vivek's been going to all the sessions that he can, but we've also been having meetings in between with some of our funders and, with Mark McClellan, who's, working very closely with CMS. And so there've been a lot of really rich conversations. And I know you're not ready to unveil your strategy yet. He starts in January, right? So, but I wonder, what are the 2 or 3 things that you take away? And, we've been having weekly discussions too.
Yeah.
So.
Well, I feel like I finally understand the state of healthcare data interoperability, and it's as bad as I feared. But you all are fixing it, which I'm really excited about. So I know what CQL stands for, and I can spell fire correctly. So I feel good to start in January. But you know, really, as a clinician and someone working with clinical teams, I think patients think this stuff is all there for their clinicians, and it's not. And so I think this community has a really clear plan and vision, and I want to be fully supportive of that great work that's been started. And I want to get to the point where producing the insights is not the work. The work starts, the opportunity to help people improve their health starts at the point of having the insight. And there I think we unleash a totally new wave of meaningful, clinically rich insights that help patients and families, help clinicians caring for them, really understand health over time in a very personalized way. We've talked about chronic condition management. There's obviously HEDIS measurement metrics that are around how well is your diabetes or other conditions managed, but these issues compound. And to really inflect someone's health over time takes time. And so we need to look at their health and whether their conditions are optimally managed over time and make sure they're getting optimal care. That is how we bend the disease curve, the morbidity curve. People stay more functional. They don't end up on dialysis or with strokes or heart attacks that could have been avoided. So I think chronic condition management, and then obviously the tie to specialty care, because people see more specialists than they see their PCPs in a given year, especially as we get older. And so we have to reckon with the fact that a lot of what we used to conceive of as just being in primary care's domain is actually in mental health, and it's actually in medical specialty care. And we need to broaden and enlarge them, like you said. On the accreditation and managed care side, you know, I think there's problems that are very apparent to people about the way health plans are set up right now. They're ghost networks. You know, just because someone's listed in the directory doesn't mean you can actually access someone. And so I think we have an opportunity to work together with the community to say, let's plant our flag. What is that next aspirational vision? Because the standards are really a guidepost, they're part guidepost and part instruction manual. But they reflect this kind of commitment across the community that we can be better and we can define what that looks like. And some of us are going to go for it. Yeah. So I'm excited about all of those areas.
So one of the big things that looms over our work is I think the public has some beliefs about high quality. There's a belief that if it costs more, it's probably better. I think that's often the case. I don't think that's the truth. I think that's often what people think. That managed care is there to get in your way. And I was very impressed with Sachin Jain's presentation on Monday because I think we're not going to win the hearts and minds of patients if they consider managed care to be just something that's about saying no. So I wonder if you had, like, what is our role in this? I actually think there's a lot of discussion happening among plans.
Yeah.
You know, because of the United CEO, that whole horrible situation and so on. But I wonder, do we have a role to play there? What do you think?
I think so. I think everybody who's an actor in the ecosystem has a role. And I think you're right. No one likes the current system. But to create transformative change is going to take everybody, and it's going to take some people to lead. And I think the health plan space is probably in a moment where competing on the same dimensions is no longer sufficient. You know, things are kind of at set points. And so there are health plan leaders looking for ways to differentiate on patient and consumer experience, on the service level, on representing themselves as, you know, the whole person, or at least in support of the whole person. And then obviously working with medical groups and clinicians in service of patients. And so I think we need to mark that territory, Peggy, and work with everyone to say, what is that next vision? We can be better. And look, people aren't going to tolerate this forever. You know, the math doesn't keep working forever. And it's going to come in different angles from consumers, from funders, from payers, and from medical group providers. So why don't we just get together and go there together?
Yeah, I think that's right. I'm a little confused about the time here.
I think we're done.